This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending in Neurosurgery.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from the journal Medicine, set to be published in May 2026. It's titled Risk Factors of Significant Intraoperative Blood Loss in Unilateral Expansive Open-Door Cervical Laminoplasty for Cervical Compressive Myelopathy, a retrospective observational study.
This is a timely topic, Alara. Cervical spondylotic myelopathy, or CSM, is something we see daily, while unilateral expansive open-door cervical laminoplasty, or UEOCL, is a representative and relatively concise procedure. Significant intraoperative blood loss, or SIBL, is still a hurdle we face. It's not just about the volume, it's about the physiological consequences.
Exactly. The authors define SIBL as an intraoperative blood loss of 500 milliliters or more. They point out that SIBL can lead to hypotension, tissue hypoxia, and even nerve ischemic injury. It can really prolong recovery and elevate the incidence of operative complications.
And in an era where blood supplies are often tight, managing these risks is critical. So tell us about the patient cohort in this study.
The researchers at the General Hospital of Northern Theater Command in Shenyang looked at 384 consecutive individuals who underwent UEOCL between 2013 and 2019. After excluding cases with things like intraoperative cerebrospinal fluid leakage or incomplete documentation, they ended up with 341 patients.
And how many of those patients actually hit that 500 milliliter SIBL threshold?
It was 10.9%, or 37 out of the 341 patients. They compared this SIBL group against the non-SIBL group, the other 304 patients, to find independent risk factors.
10% is significant enough that we need to be able to predict who those patients might be. Before we dive into the specific risk factors they found, let's touch on why we choose UEOCL in the first place. The paper mentions it compared to ACDF.
Right. The paper notes that while ACDF can reduce blood loss and preserve cervical lordosis, laminostomy contributes to a wider cervical motion range. UEOCL is favored for multi-level CSM because it's less invasive than some alternatives and has a lower long-term incidence of complications. However, as the authors mention, SIBL can't be completely avoided.
So let's get into the big three. The multivariate analysis identified 3 independent risk factors. What was the first one?
The first one was the presence of surgical-level OPLL, ossification of the posterior longitudinal ligament. The odds ratio, or OR, was 2.668. This means patients with OPLL at the surgical level were over 2.5 times more likely to experience SIBL.
That makes sense from a surgical perspective. OPLL often involves more complex anatomy. Previous studies cited in this paper, like those by Lee or Sun, also mentioned OPLL as a factor. When you're dealing with ossification, the venous plexus can be more engorged or the bone itself can be more vascular.
Exactly. The study emphasizes that for these patients, the surgical complexity increases. The second factor they found was the duration of the operation, specifically an operative time of 150 minutes or longer. The OR there was 2.598.
It's almost a chicken and the egg scenario, isn't it? Does a long surgery cause more blood loss, or does the blood loss make the surgery longer because you're constantly trying to achieve hemostasis?
The authors suggest it's a bit of both. Longer surgeries naturally involve more time for raw bone surfaces and soft tissues to bleed. They mention that surgical time is a well-discussed predictor of blood loss in cervical laminostomy.
Now, the third factor was preoperative FIB, fibrinogen levels. This one is interesting for our residents and students to pay attention to. What did the data show?
The OR for preoperative FIB was 0.480. Because the OR is less than 1, it indicates that higher preoperative fibrinogen levels actually acted as a protective factor. Conversely, lower fibrinogen levels preoperatively were an independent risk factor for SIBL.
That's a crucial takeaway. Fibrinogen is essential for stable clot formation. If a patient is on the lower end of the normal range, they might not have the same hemostatic reserve when you start opening the door of the laminostomy and exposing all those venous plexus.
It's worth noting that the authors specifically looked at several other factors that didn't end up being independent risks in the multivariate model, even if they look significant in the univariate analysis. They looked at age, sex, BMI, and even the number of segments operated on.
Did the technique matter? For example, the use of lateral mass screws versus centerpiece mini plates?
Interestingly, no. The technique, whether it was lateral mass screws or a centerpiece, didn't show a significant correlation with SIBL in the specific study. They also looked at the duration of limb symptoms, which didn't turn out to be a factor either.
Let's talk about the consequences for the patients who did have SIBL. Did it actually change their hospital course?
This was one of the more surprising parts of the study. For the SIBL group, there was no significant increase in postoperative drainage. The p-value was 0.636. There was also no significant difference in the length of hospital stay or the total hospitalization cost.
That is surprising. Usually you'd expect a patient who loses half a liter or more of blood to stay longer for monitoring or recovery.
True, but there was one area where the difference was massive: the frequency of blood transfusions. The p-value there was less than 0.001. So while we are managing these patients well enough that they aren't staying longer or paying significantly more, we are relying heavily on blood products to get them through.
And that brings us back to the importance of preoperative screening. If we know a patient has surgical level OPLL and their fibrinogen is low, and we anticipate the case might go over 2.5 hours, we should be preparing.
Exactly. The author suggests that identifying these SIBL-related independent risk factors before surgery allows us to identify specific patients who need intensive care in advance and to adopt corresponding measures.
Let's dive a bit deeper into the surgical level OPLL aspect. The paper mentions that UEOCL is often used specifically for OPLL because it allows the spinal cord to shift posteriorly. But the study suggests that the occupying ratio, or the space relation of the K-line and osteophytes, can play a role.
Yes, they mentioned previous literature where an occupying ratio of 60% or more was a factor. While this study focused on the presence of OPLL itself, it aligns with the idea that the more crowded the canal is by ossified tissue, the higher the risk of bleeding during the decompression.
And what about the operative time? They used a cutoff of 150 minutes. For a resident learning UEOCL, that's a very standard time frame.
It is, but for those more complex cases where you're approaching that 150-minute mark, the cumulative blood loss from the muscle stripping and the laminotomy edges really starts to add up. The authors call it out as a major predictor.
It's a good reminder for the junior residents listening. Efficiency isn't just about finishing the case, it's about physiological preservation. The longer that door is open and the edges are exposed, the more those small volumes of blood loss accumulate into a significant event.
We should also mention the limitations of the study. It was a retrospective observational study at a single center. While 341 patients is a good sample size compared to some previous studies, it's still retrospective.
Right, and they excluded patients with intraoperative cerebrospinal fluid leakage, which in itself can be a marker of a difficult case. But for a standard UEOCL for CSM, these findings are very applicable.
To summarize for our listeners, if you're planning a unilateral expansive open-door cervical laminostomy, keep an eye on 3 things. Is there OPLL at the surgical level? Is the preoperative fibrinogen on the lower side? And do you anticipate the surgery will exceed 150 minutes?
If the answer to those is yes, you might be looking at a patient who has a nearly 3-fold increase in the risk of losing more than 500 milliliters of blood. You should have blood products ready and perhaps be even more meticulous with your hemostasis from the very beginning.
And remember, while SIBL might not keep them in the hospital longer or increase their bill according to this data, it will significantly increase their chance of needing a transfusion.
Great summary, Dr. Alara. This study provides some very practical metrics for us to use in our preoperative huddles.
Thank you, Dr. Aris. It's always interesting to see how these retrospective reviews can refine our clinical intuition.
That's all for today's episode of the Neurosurgery Hub podcast. We hope this look into the risk factors for intraoperative blood loss and laminostomy helps you in your next clinic or OR day.
Until next time, stay curious and keep learning.